Nigeria is among the 30 high TB burden countries due to limited access to TB screening and testing services. But with support from USAID, the National TB Programme, the Stop TB Partnership and aligned stakeholders, Bashir Ahmad, a local radiographer, is able to set up and run systematic rapid screenings in Nigeria's most remote areas. He is on the front line, saving lives, cycling to hard-to-reach communities using the ultra-portable digital X-ray system and computer-aided detection, or AI software.
It's my responsibility to take the examination in terms of position the patient, then we'll collect his samples. CAD for TB is really helping because actually it can detect TB at early stage. That's the first one. And secondly, the heat map can show you the patches around the chest. If there is any patches, you'll see it with your eyes. It's my town, my community, my people. So it's a dream. So I want to give back to them by helping them or by doing this work. It's my passion. I want to follow my passion.
All right. So Delft Imaging webinars serve as a platform for experts and partners to share their experiences and invaluable insights. We are pleased to have you join us for yet another exclusive Delft webinar. My name is Baaba Pobee, and I'll be your host for today. So today's agenda is on applying evidence in practice, global insights on X-ray and CAD deployment. Before I take the pleasure to introduce our guest speakers, let us please note a few instructions, okay? So this webinar is being simultaneously interpreted in French, Spanish, Russian, Arabic, and Portuguese. Please be sure to click on the interpretation button to select your preferred language. I'm going to take that again. So the webinar is being interpreted in French, Spanish, Russian, Arabic, and Portuguese. So to listen in your preferred language, you need to click on the interpretation button. Also, there will be a Q&A session, and so we encourage you all to leave your questions in the Q&A box instead of the chat box. So right next to the chat box, there's a Q&A box as well. So if you have any questions, please leave them in the Q&A box instead. All right, so on our lineup for today and our guest speakers, I'm pleased to introduce to you Mr. Dennis Ngosa, a consultant at the CIDRZ Analysis Unit in Zambia. We also have Ms. Lillian Kerubo, National Coordinator for Active Case Findings, Quality Improvement and Chest X-rays at NTP Kenya. We also have Mr. Elvis Muriithi, ICT and MEL Specialist at the Center for Health Solutions, also in Kenya. All right, so we have our own Mr. Florent Geerts, Business Unit Director at Delft Imaging, also Mr. Mohammed Harbiye, also Business Unit Manager at Delft Imaging. So we want to kickstart right away, and so I'm going to give the floor to Florent to take over.
Yes, thank you, Baaba, and good morning, good afternoon, and good evening, everybody. Just a quick word of welcome for today, indeed, about the topic of how we go about turning evidence into practice when it comes to TB screening, and looking specifically on deployments related to X-ray and CAD. If you can go to the next slide, please. So the reason why we have these webinars, and this is the last one actually from this year, so we wanted to do it right before the union conference, is that I think it's important that we can all learn from each other's experience. So every single quarter we invite people, partners from us from all over the world, to talk about their activities using X-ray and CAD. And we want to look together at what worked well, what challenges were encountered, because that's what we learn most from. And of course, also what's next, what are the improvements that have been made, new innovations, new changes, and so on. So we had 3 already this year, actually in the first quarter, the second quarter, and also one specifically for Latin America. That was also translated actually to, it was in English as well, and in Portuguese and in Spanish. And many of the webinars that we do are in parallel translated to multiple language, like the one that we have today, like Baaba mentioned, in 6 languages today to make sure that everybody can follow it. And they're also available via our website, actually. So I'll put the URL here downstairs. So you can see delft.care/client stories. So you'll see there, I think about now maybe 40 different videos from people across Latin America, across Africa, Middle East, Asia, basically talking about their programs and their research when it comes to TB screening. So have a look there. Perhaps there are certain cases in similar settings, whether it's prison screening, community screening, that your program might be able to benefit from as well. Next slide, please. The reason that we also do these webinars is because a lot has changed. And of course, I put a picture here from way back in the day, actually from one of our previous companies from NROF at the time, still here in the Netherlands. Of course, we still had these very analog X-rays, but the change to digital X-rays that we have right now is still ongoing. So there's a lot of countries around the world that, of course, are still using analog X-rays and kind of making that transition into digital X-rays. So that's really the first part, I think, where we want to share some insights together that we can learn from. So there's, of course, the difference going from analog, like we can see here in the Netherlands on the left, and also here on the right, we see in a portable setting with the digital X-ray system, the Delft Light, somebody from KNCV actually in Nigeria working with the system. So we go to the next slide. The other change that I think is happening right now is that where, a number of years ago, X-rays were also mostly stationary always, so based within a hospital and clinics and various sites. We're now working with X-ray systems that have gone fully portable. So like here, for example, being set up in Nigeria, this actually is as well, I think, a member of the KNCV team in a program supported by USAID and also the Stop TB partnership, where X-rays now on actually can actually be set up in more remote settings where normally these X-ray facilities aren't available. But of course, a portable X-ray system means different questions around how do you tackle radiation and so on. And those are, of course, also important to understand from other programs that are already utilizing this, how they're going about that. So that's also one of the things that we always want to tackle into these webinars, that we understand, okay, what are these changes that are now happening in the TB screening environment and what can we learn from that? And if you go to the slide. Of course, the other change that we're now that we've been making now for quite some time is that where we normally would focus mostly on human reading of X-ray images, and the left here you see, of course, an analog X-ray image, but it applies the same to digitally one, that we're now more and more moving into the utilization of computer-aided detection, of also referred to as artificial intelligence software, like we can see here on the right, CAD4TB being used in Uzbekistan, really supporting the people on the ground with a very rapid method of detection of abnormalities related to TB before they can be followed up by confirmatory testing. So that's another change that's I think that has brought a lot to TB screening that we often talk about in these webinars. And if you go to the next slide, please. So there's a ton of different countries, of course, utilizing these tools, and we'll talk more about that later, but also in a ton of different settings. So if you can click once, Ian. So you can see here, actually in Uzbekistan, members of our team were there this week, really setting up TB screening efforts using the Delft Light portable X-ray in various sites around the city. But if you then go click again and you see here, you see Nigeria, again, the program from KNCV and also IHVN is very active there, supported by USAID and the STOP-TB partnership, setting up in more remote areas of the country, really making such X-rays facilities available where it normally wouldn't be. But also if you click again here on the right side, in Bangladesh, we see it, for example, these same types of systems that are portable, but then set up more in like a hospital and clinic types of setting. So you can see here in Bangladesh, such sites using both the Delft Light X-ray as well as CAD for TB. So different countries, different settings, different contextual challenges that they might encounter. But again, valid learnings, I think we all can learn from. So that's why today we'll have our fourth webinar of this year. The last webinar of this year is right before the Union Conference. We appreciate everybody taking the time. I'm sure that everybody must be busy in preparation of the conference and we are very grateful for our speakers that we have today from Zambia and also from Kenya to talk about their research and latest innovations that they've been working on. We thank everybody for being in this webinar. So hopefully we'll be able to provide you with some interesting insights. So if you go to the next part, Ian. So apart from my brief word of welcome, what we really also wanted to do briefly before we go on to our speakers is to do a quick year in review from our side. So normally during the webinars, we always invite, like I mentioned, our partners basically to speak about their efforts on the ground. And I think that's, of course, the most important one. But because we're looking at the closure of the year, we also wanted to shed some light on how we have been supporting programs and what we have been experiencing to provide also some context from our side, of course, being a solution provider in this field. If you go to the next slide. So firstly, looking mostly at, why is there a push now on X-ray, and specifically portable X-ray and also CAD software? So there are a lot of policy and information notes around this. So I've put some here from Global Fund in USAID, and you see the policy notes on the left side. But also Global Fund recognizes the limitations of symptom screening. It's working to update policies and plans to significantly scale up systematic screening for TB using digital chest X-ray and also CAD software. Furthermore, there are plans to scale up and improve the quality of systematic screening at a nationwide scale, going beyond just smaller projects and using sensitive TB screening tools and algorithms. And these nationwide scale we'll be talking more about later as well. To decentralize TB screening and testing into primary healthcare facilities, as well as community and household levels, including through mobile clinics fitted with portable digital X-rays, whether that's with or without CAD, to be able to offer more accessible community-based early diagnosis. That's, of course, also then looking at the mobile clinic side, apart from the X-ray side, which we'll also talk about more later. And to prioritize WHO recommended diagnostic tools and algorithms that are sensitive, accurate, and efficient, including the use of chest X-ray, again with and without CAD, for TB screening. And of course, last but not least, there's been an extensive amount for funding under the C19RM, the COVID-19 response mechanism, which has also put a lot of X-ray facilities and CAD facilities into place. And on USAID side, we also see them discussing about the design and implementation of proven, high quality, cost-effective, and systematic TB screening interventions, and that increase access to new technologies such as mobile digital X-ray with AI. So that is a little bit about the policy behind it, to provide some context about why more and more countries are talking about the utilization of X-ray, specifically portable X-ray and CAD software. So if you could go to the next slide. And indeed, so I talk about X-ray, that's also what Global Fund and USAID talk about, but there's especially a big emphasis now on portable X-ray. So we see here different sites like Uzbekistan, Lebanon, Nigeria, working with the Delft Light X-ray. Lebanon actually is multiple country project for IOM, also in Syria, in Libya, in Iraq, and other countries. But there's a big push on portable X-ray, again, I think largely because, of course, these portable systems have the ability to facilitate X-ray screening in locations where that otherwise would not have been possible just with stationary X-ray. Now, if you click again to the next slide, At the same time, we see a lot more validation again coming on the CAD side. So there was already a lot of validation, a lot of papers, especially around the endorsement of WHO in 2021 on CAD. But there's still a lot being published about the utilization of CAD in different sites, different settings. And as Baaba mentioned, we have Mr. Dennis with us today, who will also talk about some of the research that he has conducted in this field. Next slide, please. So looking at what we've been able to implement, so 74 countries now in total, especially since the endorsement from WHO and again new focus on X-ray and also now on CAD. Been implementing a lot of projects, which we'll talk about later, but 74 countries around the world using different of our solutions and services. More than 1,800 health facilities reached, more than 1,000 capacity built for different health professionals around the world, and 20 million people impacted by the different solutions implemented. Our headquarters, of course, we organized that from the Netherlands, but with support also from Ghana, as well as our office in Indonesia. And we've been working very closely with our partner on the ground in Nigeria to also set up Delft Imaging Nigeria because of the large install base that we have in the country. And I'll talk more about that later as well. Next slide, please. Yeah, so when I talk about global rollouts, we wanted to provide some insights again from us as a solution provider, what that means. So looking at 2021 until 2023, been able to put over 380 Delft lights in the field and an additional 700 CAD/TB installations. So that's just in the past 2 years. And as you can see from the different countries mentioned here, that is really across all continents, across all regions, going from like Bangladesh to Zambia, like we see on the Delft light side, and from Armenia to Zimbabwe, like we see on the CAD/TB side. So we really also on our side, really that policy and those information notes that we looked at earlier, that enhanced focus on X-ray and CAD also being put into effect by countries in the further utilization of these tools. Next slide, please. So we see that in different projects, and there's some, of course, that are new partners of ours and quite recently started to utilize these tools, especially in this past period that I mentioned. So, for example, we see Tajikistan or Uzbekistan starting to work with the Delft lights and with CAD/TB, but also partners like ICDDRB in Bangladesh that have already been partners of ours since 2014, working with stationary X-ray at the time, as well as with CAD/TB, and that are now expanding very rapidly with new portable X-ray solutions, also in programs supported by USAID and supported by others. So it's a combination again of people that have long utilized, X-ray, and some that are now starting to use especially portable X-ray and CAD/TB for the first time. If you go to the next slide, please. We see the same also across the African continent. So, and I should mention also here, it's not just on the portable X-rays, but a lot of them, of course, also still the utilization of mobile clinics, like in Ethiopia, for example, utilizing mobile clinics, now expanding with mobile X-ray systems, both with CAD/TB. Malawi working with mobile clinics already for a long time, now expanding that with mobile X-rays, with portable X-rays, and so on. And I think that's why it's so important also to these, client stories, like we put them on the website. They're so important because there might be sites that have been using mobile clinics already for a long time that other programs can learn from. And the same for the learning curve now on the utilization of portable X-ray and CAD, so that nobody has to entirely reinvent the wheel, so to speak, together, and that we really have that dialogue to share knowledge and to share insights. If you go to the next slide, please. So it's important, we talk a lot about portable X-ray, but of course, we're really talking about a range that is meant for different settings. So we always emphasize the fact that, if you're looking at more higher portable solutions, of course, because of their size, you also lose a little bit output. So that's really a balance that we also work with all of these partners around the world to advise them in, okay, what's the setting that you're implementing this in, and what might be the best solution for that setting. So we look, for example, at, very portable systems like the Delft Ultra or Delft Lite, that, Delft Ultra are reaching about 50 to 100 exposures on a daily basis, whereas the Delft Lite still very on the portable side, reaching 200 per day, even in some sites, I know in Uganda, Nigeria, even reaching 250 a day. And then going to systems like the MAC that has been procured very extensively with C19RM funding, the EasyDR, the Compass DR, really stationary systems, and of course all of such installations into mobile clinics. So it's important again to mention that there's no one system that would benefit every single setting or contextual challenges. It's really looking at, okay, what's the most important setting or the most important system for what you aim to achieve. And of course, all of this most often in combination with CAD-AI software coming into play, looking at both then the artificial intelligence aspect of it. So having, a heat map and a score that can indicate the extent of abnormalities, but also with the broader platform being able to register their symptoms, for example, and gaining programmatic insights on what that really means on a programmatic scale. And of course, being able to combine that with service and support, such as, of course, training, which could be done on site, could be done online, could be done hybrid with both. E-learning to complement it, and of course the necessary service and maintenance. I think that's also an important aspect. We often talk about, the procurement and first implementation of these types of systems, but it's most important that these investments that are being made achieve, that we're able to have the lowest cost of ownership over time, because they've been able to utilize them for a very, very long period and make the most of it, really being able to use them effectively for years to come. So to go to the next slide, please. And I think that's really where all of this comes, together, and where we look at a total implementation, not just of the hardware, not just on the X-ray side, but also looking at the software of the AI side, the capacity building that has to go with it. Also there, not just a one-off. We often look at training, thinking when the new solutions are put into place, where we think like, okay, people need to be trained on what we've just received. But of course, over time, over many a program would utilize such solutions. People might leave the program, other people might come in. So we also look at capacity building as a continuous thing, being able to retrain people over time on the utilizations of such systems. And then the service and maintenance that I mentioned. So for us, we try to look at it together with our partners as holistically as possible, being able to implement these solutions and these services really A to Z, and being able to do that from our side under one roof. So next slide, please. Yeah, again, their service and support, of course, comes into play. So we've been really working to expand that beyond what we've already had in 2022. I mentioned, again, more expansive service support across Nigeria, but we've really seen that globally. So more and more projects across, especially Latin America, but also more across the Middle East, being able to work with IOM on a ton of different projects, often in countries that have various challenges, such as Syria, Iraq, Yemen, that of course Windows systems are put in place, need to be able to service and support them like any other country would. So we've been really working to make sure that there's service partners and that necessary support available in each and every country that we roll out projects in. Go to the next slide, please. I want to talk a little bit more about some of the infrastructural projects. I mentioned the information notes from Global Fund that talked about going beyond just smaller projects, but also really expanding to a nationwide scale. And that is also what we've seen in this, especially this past year. A lot of this, I think, also has been made possible with the C19RM funding. So we've really seen infrastructural projects like being able to implement the Zimbabwe 31 of the Compass DR stationary system, 14 Macs, mobile X-ray systems, and all of those sites with CAD-for-TB. Mozambique, 54 Delft Lights, portable X-ray systems, again, all of them with CAD-for-TB. These are truly infrastructural projects all across the country. One that we've been able to work on more also recently, Pakistan, with across different projects, but in the same time period, 104 Delft Lights portable X-ray systems and 57 mechs being put into the country, with 161 CAD for TB. So for all of those different X-ray systems. And of course, Nigeria, like I mentioned, very different long-term partners of ours, like KNCV, like IHVN, that have really expanded their utilization of different tools. So that whole range that I mentioned, from the ECDR in mobile clinics to the Mac mobile X-ray systems to the Delft Light portable X-ray systems, really putting that into place. And again, all with CAD for TB. And then it's, of course, important, like, how do you implement such a project and how do you service it? And I wanted to talk a lot about that a little bit more. Next slide, please. Because I think that this is important, that, you know, like I said, it's most important that we have our external speakers always during our webinars. But it might be interesting, I thought, to also see a little bit, how do you approach such projects? Because other programs might be working towards similar efforts now. So a project like Zimbabwe, and I think a lot when you start talking about more infrastructural projects, we really focus often about rolling it out in batches. That is to make sure that, you know, the first batch is often the most challenging in terms of getting the sites ready, getting personnel ready, maybe import challenges around it. So that first batch, you really implement the learnings from that in the following batches. Also for Zimbabwe, because the Compass DR is quite a complex and intensive stationary system. So we've arranged, was actually this past week, factory training in the Netherlands with partners from the Netherlands or from Zimbabwe, also being trained here in the factory, to make sure that when they go back later, that they're able to support all of those systems in country as well, with the local service partners that we have. Multiple ones actually, but also Mozambique rolled out in 2 batches, first a batch of 10 and then another 44 being added. And then, of course, there's often a question, how do you go about training? You know, when you have 2, 5, maybe 10 systems, that is not as complicated yet, because you might have 2 or 3 people that are being trained per system. So you're looking at training 20, 30 people at the same time. But if you're looking at 54 and you want to train 3 people for each, you're already looking at more than 150 people. And then you don't really have, but it's not feasible anymore to do that in one training, but it is very beneficial if you do that in more centralized settings, so that also that group can learn from each other, connect with each other, also, of course, from a logistical point of view. So we organized there 10 centralized training sessions in different provinces, different regions across the country, again, supported by a local service partner. And Pakistan being rolled out now, like I mentioned, multiple different projects coming together in the same time frame, also looking here at different centralized training sessions and supported with a local partner. I think those local support is always very important, because being able to support 161 sites across the country, that's only feasible when you, of course, have the right infrastructure in the country in place. Next slide, please. Yeah, so we've talked a lot about, you know, these new projects that have come in, especially in the last 2 years, but also what we've done a long time already before that. So what we've been working on quite actively on our side is also to put all of this into a new project book that we're launching, where all of those projects are featured across all of those different countries, all TB projects, all with real on-the-ground implementations, all in-country deployments. So really deployments of, you know, whether it's X-ray or CAD on the ground. And again, to make sure that also others can learn from what has might happen in similar settings. So this is something that we'll be sharing electronically with everybody who attended and registered today. And we'll also, of course, have them present during the union. So then if you stop by our booth, we can give you also a paper version of it. Next slide, please. Yeah, last part still from our side. So for the same effort, for the same reason of knowledge sharing and experience, we've been pushing a lot of improvements also and updates on our website as well. So we've set up 3 new pages, basically flagship projects that we've implemented, looking at larger scale ones. Could be, for example, Nigeria, where we build a install base over time with partners, but also quite singular, larger projects like being able to implement for OM, or with the new tools project, INTP, which is funded by USAID and supported by the Stop TB partnership, implementations for a little over 60 systems at the same time across 7 countries. You know, how are those projects supported? Who is involved in that? How does that work? So that really can be found under the flagship projects. Again, the insight of everything that we've been able to implement for our partners in all of those different 74 countries can also be found now on the website. And most importantly, you know, because these are, of course, you know, what has been delivered, what is available already in these settings. The most important part is how is this used? And I think that is really where the client stories come in, that with the support of, you know, like the speakers today, and with all of them that have gone before then, have been willing to participate, to share their experience in our webinars. We put all of them there so that others might learn from their experience as well. So that was the part that I wanted to talk about today. I want to spend more time listening to our speakers that will talk more about research that they've implemented and also new innovations that they've been working on. So that was it, at least from my side. So I'll hand it back over to you, Baaba. Thank you.
All right, thank you so much, Florent. Thank you so much. Okay, so in the next 15 minutes, I'm going to hand over the floor to Mr. Dennis Ngosa. I've already introduced him. He's going to give us a presentation on assessment of non-tuberculosis abnormalities on digital chest X-rays with high CAD for TB scores from a tuberculosis prevalence survey in Zambia and in South Africa. So Mr. Dennis Ngosa, the floor is yours.
Thank you very much. Good morning, good afternoon, and good evening, everyone. I'm glad to be part of this webinar, and many thanks to Delft. My name is Dennis Ngosa, and I'm from Zambia. I work for Sliders under the analysis unit, but my presentation is based on research work that we did with Zambia from May 2021 to August 2023. And this work was part of my thesis at the time that I was pursuing a master's degree in epidemiology. Next slide, please. Yeah, so on the background of this study, TB remains one of the 2 top infectious diseases with highest disease burden worldwide. And in the past few years, there has been an increase in the use of artificial intelligence systems such as CAD-TB to help with active case finding. And Zambia and Delft Imaging have a long-standing partnership in artificial intelligence TB screening. And one of the projects where they partnered on was the TREATS project of 2018 to 2021, which was an EDCTP funded project. And the aim for this project was to measure the impact of house level combined HIV and TB prevention intervention on the burden of TB at population level. Next slide, please. And the TREATS TB prevalence survey was one of the studies that were under the TREATS project. So this TB prevalence survey was conducted in 21 communities. That's 12 communities in Zambia and 9 communities in Africa, in South Africa. And the aim for this TB prevalence survey was to assess the impact of universal testing and treatment intervention on the prevalence of bacteriologically confirmed pulmonary TB. Next slide, please. And here what we are seeing the field processes that happened during the TREATS TB prevalence survey, whereby there was household enumeration of individuals, and then the individuals that visited the mobile field sites, there was symptomatic screening as well as chest X-ray screening that was done. And this was followed by assessment of sputum eligibility. Then sputum collection was conducted. Then the TB status was then determined through the review of chest X-rays, as well as through clinical review meetings. Next slide, please. So these clinical review meetings, the main aim was simply to just determine what was a TB case and what was not a TB case. But then it was actually observed that not all individuals that actually had a high CAD-4 TB score actually had TB. So this was based on CAD-4 TB version 5 that was used at that time. So then at this point, more interest grew in trying to do another nested study to try and quantify the non-TB abnormalities on this specific group of chest X-rays that had a high CAD-4 TB score, but TB was not diagnosed. Next slide. So then this now takes us into the study of assessment of non-TB abnormalities. And the overall aim for this study was actually to investigate non-TB abnormalities identified on digital X-rays with high CAD-4 TB scores from a TB prevalence survey in Zambia and South Africa. And two specific objectives. The first one was to determine the prevalence of non-TB abnormalities on digital X-rays with high CAD-4 TB scores. And the other one was to characterize non-TB abnormalities on digital X-rays with high CAD-4 TB scores. Next slide, please. In the methodology for this study is that it was a cross-section analysis that we did nested under the Treats TB Prevalence Survey. And the population was individuals that were aged 15 years and above, coming from these 21 communities that participated in the Treats TB Prevalence Survey. And we included only those that had a high CAD-4 TB score. And we excluded those that had microbiologically confirmed TB. We also excluded the ones that were on TB treatment during the TB Treats Prevalence Survey. We also excluded those that had a self-reported history of TB. So the study sample size was 525 individuals. These were the individuals that met the selection criteria for this study. And the main outcome variable for this study was non-TB abnormalities. Next slide, please. So they extracted 525 images of these individuals were then given to external consultant radiologists. So we partnered with two of them. And these consultant radiologists had over 20 years of experience in image reading. So two separate online accounts were developed, and the readers, the radiologists were blinded from each other. And we did a pilot reading on about 20 images. And then the main reading of these images happened from February up to March 2022. Next slide. So what we are seeing here is the study flow chart. So starting, since it was nested under the Treats TB Prevalence Survey, what we are seeing on top there is that a total of 122,381 individuals were enumerated, and out of these, 83,092 were eligible. And from these that were eligible, only 49,556 individuals visited the mobile field sites during the Treats TB Prevalence Survey. And out of these, 49,047 had chest X-rays with CAD-4 TB taken. And then out of these, 1,877 had high CAD-4 TB scores. So from these 1,877, after removing those that had were diagnosed with TB, then we also removed those that had a self-reported history of TB, and those that were currently on TB treatment during the TB Prevalence Survey. That is how we now remain with 525 individuals as a sample for our study. Next slide, please. So here, this table is showing the image reading and characteristics of participants with high CAD-4 TB scores from the TB prevalence survey. So overall, from out of the 525 images that were read in this study, 46.7% of them had non-TB, suspected non-TB abnormalities. And then out of the males, it was actually found out to say about 45.7 had non-TB abnormalities, while for the females, it was, for the males, it was 47.6% that had non-TB abnormalities, while among the females, it was 45.67 that had non-TB abnormalities. And then when we look at the median CAD-4 TB scores for those that had non-TB abnormalities, it was 83. And those that had no non-TB abnormalities, it was 79. And there was actually some statistically significant difference in the median CAD-4 TB scores. And among the images that came from the South African communities, about 45% of them had non-TB abnormalities. And among the images that came from the Zambian communities, about 48.2% had non-TB abnormalities. Next slide, please. So the overall inter-reader agreement, the observed agreement was about 63%, and then the kappa value was about 0.2. Next slide, please. Next, yeah. So this table is now showing the prevalence of the non-TB abnormalities on these digital chest X-rays that had high CAD-4 TB scores. So a total of 26 non-TB abnormalities were reported, and then we characterized them into the anatomical region where they were actually found. That was the lung parenchyma, the pleural space, the mediastinum, as well as the heart and great vessels. So the most prevalent one came from the pleural space, which was pleural effusions, which was about 8.8%, and this was followed by cardiomegaly, which was sitting at 5% from the heart and great vessels. But we also had multiple prevalences being reported in the lung parenchyma. For example, pneumonia not typical of TB, sitting at 2.7. We also had chronic scarring sitting at 2.1. We also had mass nodules, which were suspected to be malignant or benign, sitting at 2.1%. Next slide, please. So when we tried to now look at the non-TB abnormalities based on the anatomical location, what we are showing here is that most of the non-TB abnormalities that were reported were in the lung parenchyma. This was followed by the pleural space and the heart and great vessels, and then lastly we had the mediastinum. Next slide. And on this next slide, what we are seeing is we tried to now categorize this by country, but then we didn't really see major differences in the non-TB abnormalities based on the anatomical location by the two countries. Next slide, please. So here what we have, we are showing a box plot showing the distribution of CAD-4 TB scores on digital X-rays that had non-TB abnormalities. And what we are seeing is that for lung parenchyma, pleural, heart and great vessels regions, the median CAD-4 TB scores ranged from about 78 to 80. And then mediastinum had the highest median CAD-4 TB score, which was sitting at 86 at the end there. Next slide. So summary of the findings from this study are that out of the 525 chest X-rays that were read in this study, 46.7 had non-TB abnormalities, and out of these that had non-TB abnormalities, 11.4 had multiple non-TB abnormalities, meaning more than one non-TB abnormality. And the most prevalent anatomical location was lung parenchyma, which was followed by the pleural space. And the most prevalent non-TB abnormalities was pleural effusion, and then that was followed by cardiomegaly. And generally, we are saying that a wide range of non-TB abnormalities, suspected communicable and non-communicable diseases were reported. Next slide. So the implication of the findings from this study are that CAD-4 TB might have potential to incorporate algorithms to read for other non-TB abnormalities that might be of clinical relevance alongside TB, which is like the primary focus for CAD-4 TB. And given the rising burden of communicable and non-communicable diseases, it is increasingly becoming necessary for CAD-4 TB to have the capability to simultaneously identify other causes of abnormal chest X-rays alongside TB. And some of the abnormalities that might be considered based on this study might be pleural effusions, which is normally indicative of a wide range of underlying conditions in individuals. And we might also maybe consider also cardiomegaly and also mass nodules, which might be indicative of some possible lung cancer. And we feel that this can actually make CAD-4 TB even more attractive for the end users in TB active finding cases, because then in situations where TB is not found, but the chest X-rays are abnormal, then we are actually capable of maybe trying to look out for the other causes of abnormal chest X-rays. And this might be very useful, especially in low to middle income countries like Zambia, that do not routinely screen for non-TB abnormalities due to a wide range of challenges, among them shortages of qualified radiologists. Next slide, please. So the strengths and the limitation of this study is that under the strength, we had partnered with consultant radiologists with over 20 years of experience in image reading, and they had experience in doing similar work in other TB prevalence surveys. And we also had a long list of abnormalities to read for, which brought out about 26 non-TB abnormalities. And the radiologists were also blinded from one another to avoid a reader bias. But under the limitations, we do acknowledge the fact that TB cannot 100% be ruled out through bacteriological tests. So it might have been a chance that the bacteriological test might have actually missed some cases. And the prevalence that has been reported in this study was based on radiological diagnosis only. And we acknowledge the fact that some non-TB abnormalities might actually need further medical investigations. And yeah, next slide, please. So this work that I've presented on is actually published under the BMC journal. Next slide, please. And like I said in my preamble, to say this study was actually nested under the TREATS TB prevalence survey, and the TREATS was funded by EDCTP. Next slide, please. And we are grateful to the TREATS TB prevalence study team, and we are also grateful to Delft Imaging Netherlands, and also very much grateful to the 21 communities that participated in the TB prevalence study where this study was nested. And yeah, thank you very much, everyone. That is the end of my presentation. I submit back to the chair.
Thank you so much, Dennis. It's also interesting to see that a lot of people are interested in your research. We are getting a few comments in the Q&A section, chat box, I mean. All right, so moving right into the next presentation, I'm pleased to introduce Ms. Lillian Kerubo and Mr. Elvis Muriithi. So this is actually a two-in-one presentation. So I'm going to give the floor to both of them to give us their presentation as well.
All right.
Thank you, Julia, for this time. So, as introduced, my name is Lillian Kerubo. I work for the National TB Program, and I'm responsible for coordinating active case finding activities, chest X-ray, and quality improvement. And so today we are going to share on integration of TIBULIMS and CAD for TB and get to learn the lessons from our country, Kenya. And so I will start off by mentioning on the introduction of the new projects in our country following the guidance from WHO on the use of the new tools. And so for this implementation, we were supported through USAID and Stop TB Partnership, so that we are able to implement the 3 projects. That is the digital adherence technology, TIBULIMS, lab diagnostics, TPT, and digital chest X-ray. So I will quickly allow my colleague to do the presentation, given that we have 15 minutes to share our experience. So I would want to ask Elvis to take over and present our lessons learned in our country. Thank you, Elvis.
Thank you, Lillian. Thank you, Julia. And thank you, everyone who has logged into this call. Allow me to take you through the integration process of TIBULIMS and CAD for TB that we implemented here in Kenya. I understand that we were the first country to do the integration with CAD for TB with our local LMIS. Just to introduce the LMIS, it's called TIBULIMS. It's more of a diagnostic connectivity system, which connects the gene experts, the TrueNut, and now we have the CAD for TB on board. So this system is now 10 years old. We started with Gene Expert previously, and as my colleagues said that through the support of the USAID and Stop TB, we saw the introduction of the new tools, whereby the TrueNut came on board, and now the CAD for TB, that was in 2021 and 2022. And I'll ask the tech team to go to the next slide, please. So the NTP started in July 2021, and after this, we saw now the creation of the CAD for TB, or the chest X-ray subcommittee formed. That was in August and September. And mid last year, around May, we saw now the arrival of the CAD for TB machines. And in Kenya now, we started with the hiring of the radiographers, and of course, training them to make sure that they meet the required threshold to do these images and all. In July, the launch and distribution of these machines to the various facilities was done. And through that time, of course, we have gone to the radiation assessment to make sure that our health facilities are up to the task to handle this machine, and of course, to make sure that our healthcare workers are protected from the radiation. So TIBULIMS connectivity officially was launched in December 2022. And of course, going to the next slide, please. We went through a process of, just to make sure that we are ready for the integration. So when we started this, when we launched the machines to the facilities, we saw that there were a few gaps because, and these gaps basically came in terms of data. There's that there are those variables that we wanted to measure and collect at the ground before or during the use of these machines. So we saw that the CAD for TB machines had a software that was pre-installed, and this software was used now to collect information, but it was not adequate enough for programming. Therefore, we saw that we needed now to go off the Tirona software that they used, and under the CAD for TB module to make sure that we capture more variables going forward. And that's where the thought of integrating it with our local solution, which is TIBULIMS, now came in thought. So again, we saw that these machines also were remotely accessed. Therefore, we had that the need to have this information accessed remotely, or rather within a general system whereby wherever you are, you can log into the system and access information from the various CAD boxes at the national or even at the county, at the county level. So this system was standalone, therefore we needed to do an integration with the TIBU system to make sure that information is available real time within a click of a few buttons. So going next. So just to mention that from the gaps now we saw, we thought now we needed to plan, and the process now indicates what we did now to make sure that we fully incorporated everything that we needed before now we can do the integration with our local solution. So the first thing we started was to identify the variables that we needed to capture. Therefore, within this, we saw that we brought on board various cadres. We have the radiologists, we have the radiographers who are running the images, and we have the clinical team, whereby we saw that we needed information of the triage. We needed to measure the BPs of this patient. We needed to see the temperature indicated within each and every patient that is taken an image. And therefore, this is besides the patient demographics, of course, the age, the gender, the sex of this patient. Therefore, we did identify these MND variables, and now we went on to develop what we call a business requirement document for this, for the new module of to incorporate the CAD for TB component of it. Therefore, after interacting with the Delft team, we saw that they have an API gateway. Of course, this is a big plus for the company and the machines, whereby within this API, you can exchange information from the boxes to any system that is available. So we talked with the ICT team under the Delft company, and we are able to get a way forward, and now we can exchange this data. So within the same process between August and before we did the rollout, we also made sure that we had the various views under the end users. Therefore, these views now will incorporate the new variables that we've identified within the MND framework to make sure that we collect as much information as we can for the patient just within the image. Therefore, with these views, now we are able to get dashboards at the end of the day, and which is one of our greatest achievements for this system. And of course, the reports in terms of line lists, which I'll just talk about it later. So within the system that we used to use, remember it was incorporating only the Gene Expert, but now the new tools are here. We needed to have more allocation in terms of the cloud capacity to host these systems. Remember, it's a web system, therefore the hosting and all the resources needed to make sure that you can access the system were put in place and in consideration, and these were all put in place in the facilities, did the proper testing, and of course for this particular solution, we did the pilot to make sure that it suits our needs, and of course did the configuration of the devices just before the rollout. So just before the rollout, again, we called all these cadres that we are talking about, the radiographers, the radiologists, make sure that they understand the system. You remember, there's a new solution, therefore you have to sensitize them to make sure that it suits their needs, and as per what we call the scoping, after the requirements that we are capturing before the BRD, to make sure that whatever they say that they want, now it's available to them. So that's where now the capacity building came in place, and now as we talk, as am I talking, we give that continuous support to the facilities. Next, please. So this is basically a model of what TIBULIMS is. So we have the site, we have the facilities where these devices are placed, and so I talked about the gene expert, the tuner, the CAD for TB. So the lowest CADA, or let me say the first end user is, of course, the clinician, or what we call the radiographer, the person who sees the patient. So, and that's where the primary data capture happens. So beyond the scenes, now we have the various APIs. Remember, these are systems that have their own systems that are running independently. So with the help of APIs, application programming interfaces that we've created for the gene expert, the TrueNut, and now the CAD for TB, which is the main topic today. The API runs in the background and make sure that whatever images run is now uploaded into the TIBULIMS database. And this now, once this information is available, all these CADAs towards the end, the users now are able to access and see the information as per the user rights given within the system. So the idea now of having this system, you can just click next, kindly, Ian. So the idea was now to expand the connectivity of the current TB diagnostics to make sure that the instruments that we have at the ground are able to be networked. We can make easy provision for easy integration for the future, and to, of course, to make sure that in terms of network management and relay of results is optimal, and within, just when an image is taken, results are uploading into the server, and within the TIBULIMS now, the various CADA can receive these results in real time. And of course, the mandate for this, of course, is to make sure that there is that easy monitoring of the performance of the instruments, and we can get whatever information that we need to get within the system within a click of a button. Next, please. So let me talk about the API. So as I said, Delft have a cloud repository for all the boxes. So what happens is that through this API, whenever there is internet connectivity to the box, any image that has never been uploaded into the system is now pushed into the server. And the various CADAs, you saw in the gap, one of the gap was that, and one of our wishes as a country was to have the radiologist who is not sitting within the facility able to access these images and they can give an radiological report in real time to make sure that we give the best, with the goal of making sure that we give the patient the best service in a timely manner. So one of the reasons for this is to, of course, to reduce the time a patient comes into the facility. Remember, some of them come from far away. Therefore, we want this patient to get the best care in the shortest possible time, minimizing what we call the catastrophic cost going to the patient. So within now the system, we were able now, by system I mean TIBULIMS, we're able to have the different end user modules whereby we collect the patient demographic at large. And then there's what we call the screening data. Therefore, by screening data, I mean, we were assessing the cardinal signs for TB. For example, we want to know if this patient has had a cough, if there's the fever, if there's night sweats for this patient. And of course, we want to get the triage data. We want to measure the BP, blood pressure. We want to see what is the respiratory rate for this patient. So all this information is collected prior to taking the images. So once this information is saved into the TIBULIMS, now through the API, we get now the X-ray images and the CAD scores for this respective patient. So at the end of the day, we have a data set with the patient demographic, the screening history of this patient, the triage information of this patient, and of course now the images that have been taken. So this, as I mentioned earlier, the box, as long as this box is connected to the internet and image has never been uploaded, it is pushed into the server, and we are now able to have like a complete data set of one patient. So this of course happens in real time, and as long as now the internet is available, and based on now the various the alerts, once we get the information going to the server based on the CAD score. So based on the CAD score, the radiologists are able to assess the images and give a report to it. So just something I never mentioned is that in Kenya, we work with the threshold of 40, CAD score of 40 and above has to be assessed by a radiologist. So, and we saw that it's not a big percentage. In Kenya, it's around 15% of our data, of our patients who have been taken the images do have this the score of more than 40. Next, please. Okay, so this is basically a diagrammatic representation of a setup on the ground where we have the CAD boxes. Of course, there's the digital X-ray, we check the image. Of course, there's the laptop. So we write on the laptop to access TIBULIMS. So the laptop that is provided by Delft to provide the image is the one that they use now to access the online system TIBULIMS, where they key in the patient information. And of course, once they take the image now, we have now the cloud setup with the Delft and the API, which now pushes the images to TIBULIMS, and we have that complete data set of the patient. Next, please. So what have you achieved with the TIBULIMS system, or just from the integration with the CAD for TB? We've seen that the images and the AI reports are accessible within a click of a button from wherever you are. And therefore, a radiologist is able to give the best radiological report based on the history of the patient that we collect, the screening questions, the triage information that we have. And of course, later on now, within the system now, we've been able to incorporate the aspect of feeding in the result of the laboratory, whereby anybody with a CAD score above 40 is now subjected to a DST test, either a gene expert or a TrueNut. Once the results are out, within the same system now, the result can be updated, and we can actually ascertain that anybody now going through, or anybody who is presumptive of TB and as a suggestive X-ray or as a CAD score of above 40 can be confirmed that with a radiological test, which is now the gene expert and or even the TrueNut. So we see now the turnaround time on reporting going down, because if an image is not clear and a CAD score is very suggestive, the radiologist can ask for repeat images or even additional clinical information or history from the radiographer through the system. And of importance now is to get at a glance, the status of the machines. So at any given time, we can see which machine is offline. There's a days offline. If you can all see the images that are the graph that is the bar graph, we can see the 8. Sorry, I didn't mention that we have 8, but yes, we can see the uptime of these devices by just opening the dashboard. And we can see the trends of this, the images that have been taken over time. So this is the data for 2023. You can see, the zigzag, whereby we have the highs and lows in terms of screening and taking basically the patient that have been screened using the X-ray. You can be able to see this by just logging into the system and seeing this information. And again, the reports are now available in form of what we call CSV, where if you need to do more analysis to the data, you can be able to do that. So the colorful batches just show the number of images that have been taken. Out of this, how many have a CAD score of above 60? How many have a CAD score between 40 and 59.99? And those that are below 40%. So from this, we can see a picture of our screening or our images that have been taken. And at a glance, you can see like 15% of 2023 data. We can see that they have a high likelihood of having TB because of the CAD score, which is above 40. So going to the next slide, please. So what we've learned from this project or this integration is that engaging our stakeholders is very important, because for you to get a successful system, a system that works for us, or a solution that works for us, you need to engage every stakeholder to make sure that you meet their needs before you implement such a case. So support and real-time response from manufacturers is also very important, because many a times we've seen our boxes, fail, but good thing with such a mechanism in place where the manufacturer has a help desk is very important. And in this case, Delft help us in a long way, because the help desk is always open in case we have our users at the ground or at the facility level. Having any challenge, they are resolved within no time. So continuous training and refresher to the end users is very important to ensure that the mandate that is in front of them is able and the solution is working. Therefore, support mapping of available, the strength that we can improve on, just to ensure that this kind of support is going and it's continuous, to make sure that they don't follow the track to in case of any challenge that any challenge that may arise. So again, and a very important one is to ensure that in the dynamic area of this field of TB, where we have new molecular diagnosis of devices coming up, it is important to prioritize now the issue of integration to make sure that the solutions that are creating, we can be able to integrate with the current system to make sure that, sorry for that. Sorry for that background noise. I'm in a hospital setup for some technical assistance, as I was saying. So just on the last point, to make sure that the solutions that are coming up easy to integrate with, to ensure that the data that is run on these devices can be uploaded into our systems, to ensure that there's that our reports are available by click of the buttons, and just to make sure that our analysis are adequate enough. Sorry for that again. So moving to the last part, I think that sums up the end of the presentation, and it's unfortunate that the last part was interrupted by some background noise. So as I finish, I want to acknowledge of course, the Ministry of Health, which has, through the various programs like the National TB Program, whereby we want to acknowledge the leadership, the head of the program, Dr. Immaculate Kature, for allowing us to make this presentation and supporting us through all this. Of course, we can't forget our partners in this, the USAID and the Stop TB Partnership, TBAC and CHS and PEPFAR for the funds and support towards ending TB in Kenya. So back to you, Chair. And thank you so much for listening to me. Yeah, much appreciated.
All right, thank you to Elvis, and thank you, Lillian, as well. Okay, so we are almost getting towards the end of this webinar, and at this point, I want to hand over the floor to Mohammed.
Thank you very much, Baaba. Thank you for all the speakers. Good morning, good afternoon, and good evening to all the participants. So my piece about this presentation is to present our new products and improvements, but please allow me to give a little bit of background on how these new products and improvements came about. So the whole idea of having the webinars, sharing our projects overviews, is that we can all share experiences on how our products function in the field and what we can do new to increase the impact that our products gain in screening TB patients. We are also yearly have an evaluation of all the products where we include in a booklet the impact report, all the impact different projects have. The goal of that is to also give ideas, and that's also the goal of speaking in our webinars, to give ideas to other implementing partners on how other programs are finding and detecting TB cases. But besides that, of course, it gives us also valuable information on how we can constantly improve our products to give you the latest innovations in order to get the results and increase the results year after year. And hopefully very soon we can eradicate this terrible disease, TB. So please to the next slide. The first improvements are related to our Delft Light, so the otherwise also known as Delft Light Backpack X-ray. The biggest improvement is we have reduced the weight drastically, so we have streamlined the components, for example, the detector, solar panel, and generator stand. And collectively, in total, we will become less than 22 kilograms. But besides that, besides the weight, we've also upgraded some of the subcomponents. We all know how reliable and efficient and effective the Canon panel is. We have a new improved version on that, the 703C. And by having this newest improvement, we can have a more sensitive image with less radiation, and that against a less of a weight solution. Of course, with our DLB comes the solar panel. The solar panel makes it possible to charge all the batteries that our X-ray requires. And now we have developed a new robust solar panel, which is only 3.6 kilogram. It can charge all the Delft Light components, but being 40% lighter than the previous version. And the new stand, which presented here is the old stand still, will be, instead of 12 kilograms, will go to 4 kilograms, while still having the same reliable and robustness that you are used to from our products. Next slide. As Florent mentioned, we have a variety of ultra-portable X-ray machines. The previous one, the Delft Light, can do more than 200 exposures per day. The Delft Ultra can do between 50 and 100 exposures per day. But the Delft Ultra, as presented here, it's an all-in-one system. So the below left image is the old Delft Ultra system. The right image is the newest version. You can see immediately that the screen was first 7-inch. Now it's 10-inch. It's comparable to a Apple iPad or any other iPad that is 10-inch screen, which makes it for the usability much more easygoing. And you can also zoom in, you can identify the X-ray image with a lot more ease than the smaller 7-inch screen. The integrated portable X-ray solution, the Delft Ultra, also comes with a new improved computer loaded into the X-ray, which empowers by CAD-4TB. So together, we can ensure that the CAD-4TB result will be generated in less than 15 seconds, all in one integrated system. That system, of course, comes with a X-ray detector, which by itself weighs less than 10 kilograms. and there's no need for any additional network or power connection cables. It's all wireless. So again, the image acquisition is seamless, integrated into CAD4TB suite. And of course, when the image is captured, it will be automatically generating a result from CAD4TB, which I will talk about in the next slide. A little bit about the technical details of the X-ray machine. It is a 90 kV X-ray machine at 10 MAS, and the battery capacity is enough for 100 exposures. In addition to that, we can also equip this machine, this total layout, with a power bank, which can ensure also remote charging of your equipment. Next slide, please. For the CAD4TB, so for the CAD4TB, as you see on the left image here and the right image, you see the box by itself. Again, thank you very much for your feedback from the field and from using our system extensively. We remain at your service for all those feedbacks. So the new CAD4TB box, so instead of having all of these cables, two different components, the router and the box, we have integrated everything in an all-in-one concept. So the concept of our new improvements, it's in line with an all-in-one theme. So we are trying to provide you an all-in-one solution. Not only, as my colleague Florent mentioned, we are a holistic supplier of X-ray and AI, but we want to go one step further in providing everything in an all-in-one concept. Seamless connectivity also to enhance portability with fewer cables and devices. So the new improved, furthermore, on the CAD4TB, we are also loading our newest and improved AI module of CAD4TB. And also we want to include a multiple abnormalities score, a multiple abnormalities indicator, in which if you have any abnormalities besides TB, so for a triage setting. In addition, as also from the speakers mentioned about threshold, the threshold is very important, and that's why we have included a new feature, which is the dynamic threshold. It's an optimized calibration made easy, and the threshold value is essential for the performance of the CAD4TB system. Setting an optimal threshold is critical to balance sensitivity, which is the ability to correctly identify positive cases, and specificity, the ability to correctly identify negative cases. If the threshold is too low, the system may produce more false positives, leading to unnecessary additional testing. If the threshold is too high, the system may miss true positives. And that's why this new dynamic threshold setting is very important to optimize your threshold in an automated fashion. And I have in the next slide, but an example of how that looks like. But that's maybe, please go back to the previous slide. I will go over that after I finish this slide. In addition to the improved AI modules for TB and the multiple abnormalities, we have also seen that CAD for silicosis, so the on-site or online on the cloud, AI-powered rapid detection of silicosis is something that our clients ask for. And silicosis is mostly prevalent under mine workers. And that's also a new feature which we will present now as a newest version for CAD. In addition to that, we have a new functionality for data management. So if you want to identify how many patients have you screened, what is the distribution in scores, what are the gender distributions, age distributions, all that, it's all packed in a new fashion, in a new data management, in order also for you to identify if the current screening efforts are as optimized as possible, in order to gain more impact, finding more of these missing cases, and helping more patients in getting a result or getting a diagnosis which they desperately need. And also, if you don't have any internet connectivity, but still there is a question or there is a problem that you want to provide, we have enhanced our customer support by offering offline ticketing system. Please, the next slide. So as mentioned, on the left, you have here the newest AI features. So we have, you can see it in small, a silicosis indicator, a score of silicosis, and a TB report, version 8, including the general abnormality score. And this is the output of the CAD for TB. It shows a heat map indicating the abnormalities, but most importantly, it indicates the score, which whenever it's above a threshold, it needs to go to the next stage in the triage, which depends on the program, varies between GeneXpert, TrueNAT, or something else. The threshold guided setting, as explained, this is the dynamic threshold. So based on the lab test capacities per working day, we provide a recommended threshold which you can use in order to optimize the sensitivity and specificity, and in order to not miss any unnecessary cases. Next slide, please. And now we have arrived at something completely new. We have never presented this solution, and it's a unique moment now to show you something which we have been working on so hard in order to be part of finding missing cases which normally would not have been diagnosed. So, and this is not only for children, but I would like to emphasize the infants in this case. So many infants who die from TB unfortunately go undiagnosed. And it's very difficult to identify either sputum or X-ray on infants. And that's why I think, and we all believe, that this solution could be a very appealing alternative to diagnose infants. That's anything below 3, 4, 5, 6 years old. So I would like to introduce our new tool, which is the point of care ultrasound for TB. And we call it LUS for TB. And as seen in our picture, it's the future of TB screening because of the ease of use. It is a solution which doesn't require any radiation. It's light, and it's very simple to use. Below you have 2 pictures of on-site screening in Zambia, in this case, on how the point of care ultrasound is used together with a mobile device to detect TB in these 2 patients. So how does it work? And again, I want to emphasize the point of care ultrasound could be an appealing alternative or complementary to the X-ray in TB diagnostics pathways. It's a handheld ultrasound scanner connected to a mobile device that can either be a mobile phone or a tablet. And the study that we are doing now in Zambia is to use a standardized, simple blind sweep protocol, as you see above on the thorax image. And this protocol doesn't require any visualization of images, but rather, together with an artificial intelligence, will give you an output in which you can use that output to determine whether that person needs to go to the next test or not. And for children specifically, we are doing this study as well in Zambia, where we see if other factors, for example, enlarged lymph nodes, can have a higher indication in developing TB. And we hope that with this device, we can in the future also identify those missing infant cases. Next slide. And I think this is my part of the presentation. Thank you all for your attendance. Baaba, back to you.
Thank you, Mohammed. If we can please have Florent back on the floor.
Yes, thank you, Baaba. And well, first of all, we're going towards the end of the webinar. We still have a little bit of time for Q&A. So I'd like to thank everybody, first of all, for being here in this webinar with us today, for making the time to attend it. And of course, to Dennis, to Lillian, and Elvis for their willingness to speak during it. I want to start with some questions that came in. There's actually quite a lot of them, but I'll start with some questions that were there for the different speakers involved. So I wanted to start with a question for Lillian and for Elvis. I think I see Elvis, you already answered it, but perhaps again for the group. Ponggayan mentioned the model. What is the key to link patients from all the systems like Expert, TrueNAT, and CAD for TB? Can you comment on that, Elvis? Elvis, can you still hear us? Or Lillian, alternatively?
Thank you, Florent. Am I audible?
Yes, I can hear you. Did the question come through well? Or of course disturbing you during your workday. Apologize for that. Did you hear the question, or would you like me to repeat it? Oh, you're on mute still, Elvis.
Okay, so thank you, Florent. Sorry, as I said, I'm in a facility doing some DQA. So for example, for the issue of integration with the... Talk to me 1 minute. Sorry, a trolley was passing by, so the noise. So as I was saying, the issue of the integration or having the linkage of patients in all the health systems. So we normally say in Kenya that CAD for TB is the first maybe will help us to identify presumptive TB cases. Therefore, once a patient is logged into that system, the patient can go all of the way to getting a DST test. Therefore, since with TIBULIMS, we'll be able to do that sort of linkage for all these devices. So uniquely identifying a patient now starts from the first point. If the first point is the CAD for TB, therefore the systems assign a unique identifier that goes along with the patient to the point they get a DST. So linkage of this particular patient becomes easy. Because one, we rely on the national ID, again, with the system-generated unique identifier. So again, we've done a logarithm within the systems that help us identify a patient. Let's say we combine the age, the gender, the height, and the weight to make sure that we uniquely identify a patient along the cascade. Therefore, it makes it easy to identify a patient from the first point the patient was first identified from. Let's say be it the CAD for TB or be it at the DST level. So I hope I did that satisfactorily. So again, maybe something I never mentioned is that I happen to be the developer for the system. Therefore, I think it has been easy to do some sort of linkage since I understand the system well, and therefore I know where to tap in to make sure that these variables communicate along the various, based on the devices that are in use. Therefore, I hope I do answer that question well. Thank you.
I believe so. Thank you, Elvis, for your presentation, and to Lillian as well. I think this is a really interesting presentation also because there's a lot of discussions, of course, and a lot of from the funders and technical agencies involved that really focus on interconnectivity and the ability to be more data driven in TB screening programs. And I think with what you showed, and it's quite, of course, a technical, has a big technical aspects to it, but you thought also in the achievements that you presented, I think it has a lot of it's a challenging thing to perhaps dive in with. It's the first time, to our knowledge, that this has been done. That a CAD solution has been integrated in a platform like this. We're doing a similar exercise, although with a different approach in Uganda. But this is very new, and I think it really shows that this technical exercise is worth doing together, because there's a lot of different benefits that help program to be more efficient. So thank you for sharing that with the audience. I wanted to bring up another question for Mr. Dennis. So Dennis, you already answered it. It was a question, but perhaps you can repeat it again for the group. It was a question from Rodney. Thank you for the very interesting study. The question is, how do you know these are non-TB abnormalities? It seems to assume that the question about past TB treatment is 100% accurate. Perhaps you can discuss already. I saw your answer in the Q&A. Perhaps you can repeat it for the rest of the group as well.
Yeah, thank you very much for that. It's actually a very important question. So to start with, from the list of non-TB abnormalities that were reported on, maybe we can start by saying it depends on the type of non-TB abnormality. I was giving an example of cardiomegaly, which is normally reported based on the cardiothoracic ratio. So such non-TB abnormality might have nothing to really do with whether the fact that somebody has got a history of reported TB or not. Then for the other non-TB abnormalities that might be concerned with that question, it goes back to how the study flowchart was, whereby we first got the ones that had a high CAD-4 score. And then from there, we are now removing at least those with microbiologically diagnosed TB, since it's the golden standard. But then we also acknowledge the fact that we didn't want the readers to actually read for a lot of post-TB lung changes, especially looking at the population, our population, for example, South Africa, the population actually in literature has got a lot of post-TB lung changes. So no wonder we went for that criteria of trying to remove those with reported history of TB. But we do acknowledge the fact that this could have not, it wasn't 100% accurate. There might have still been people who actually didn't report on TB, but yet they've suffered from TB. And we went on to also remove the people that were also on TB treatment during the same TB prevalence study. But then when the results, how the results have been presented, it does not mean that those with non-TB abnormalities, then the chest x-rays were normal, no, because the CAD-4 score was still high. So even those with non-TB abnormalities, the question would be, what was still making their CAD-4 scores to be high? So then in the reading, the radiologists were actually free to still report on anything that they feel. If they still feel to say this is still post-TB lung changes, they were still free to do that. If they still feel this is still TB, they were free to do that. But then even if they did that, then at analysis, then that wasn't really the focus, because then at analysis, we're only picking non-TB abnormalities. And it would actually be interesting, because it would be interesting to really see how the prevalence and the proportions would really be if at all CAD-4 can actually incorporate algorithms to read for other non-TB abnormalities. Because even on those chest x-rays, which we removed to say these were confirmed, were diagnosed with TB, there's a possibility that an x-ray that had TB on it, an individual who had TB, might also have cardiomegaly. Even those that had a low score, there's a possibility that they might have actually had a low score, but they might still be presented with other non-TB abnormalities. There might still be possibilities of mass or possible nodules indicative of benign or malignant type of abnormalities. So then the issue would be picking up these individuals and making sure that if a CAD-4 as we are screening for TB, we are simultaneously picking on these things, then we can appropriately direct them to the correct type of care. So it will really actually be interesting to see how other type of analysis could come out and really show how the proportions would actually move. So when you go to table 1, that's the reason why we are actually saying suspected non-TB abnormalities, because it's possible that some of them could have been non-TB abnormalities while others couldn't have been non-TB abnormalities. Yeah. Thank you.
Yeah, thank you, Dennis, and for sharing your presentation and your research with us. I think it's a very relevant topic at the moment. Of course, after the endorsement of WHO for AI, really so far, really only in the scope of TB. Obviously, the question comes up: okay, how does this work in relation to other abnormalities? Mohammed spoke about that already in relation to what we're doing with CAD-TB 8, the new version coming up. But it's a very big topic, so thank you for sharing that. And we're going a little bit over time. There were a lot of questions. We hope we were trying to answer as many as possible, but I want to pick up a couple that I could still answer perhaps from our side. There was a question from Leonid on the selection criteria for our local service companies. It's a very good question. Things we look at is, the availability of personnel, how big is the team, what's their background, like biomedical engineers, IT specialists. Also really depends on the scope of the kind of projects we are implementing. Is it in one specific country, perhaps only on CAD? Is it also on X-ray, or is it both? So we'll look at that. Of course, the realistic answer is also that sometimes you have to see what is available on the ground. Smaller countries or smaller islands or lower resource settings might have less available than other sites have, but we always try to make sure that we do get the best support on the ground that we can help. And I think it's also good to mention in relation to this question that when you look at CAD and when you look also, especially on the portable X-ray, a lot of support can be provided remotely. So often when we just dial in, we can solve a lot of things remotely as well. So we tend to think still, okay, we need somebody on the ground. In some cases, that is indeed the case, but we do find that a lot can be solved actually remotely. So that's good. Just to pick up a couple of other questions, perhaps that are interesting to look at. There was a question about the utilization of a box or using the cloud. I think it's good to just trying to look up the question. Yeah, I found it. What are some common challenges encountered with the use of the CAD-TB box as well as the CAD-TB cloud in low resource settings? Which one works better? The cloud, of course, requires interconnectivity. The box does not. So in essence, it really comes down to the interconnectivity. I will say that truly, I think 99% of all of our partners, virtually everybody, does use the CAD-TB box. The reason for that is that I think in terms of your screening efforts, you don't want to be dependent or reliable on the availability or the speed of the internet. So it's not just a question like, is there internet in the first place in a specific region where you're screening or in a remote site, especially in relation to portable X-ray. But the question is also like, is it quick enough to get the results, to get the necessary throughput? So I think that in most regions where TB is still prevalent, interconnectivity in terms of not just availability but speed is a challenge, and 99% of partners do end up using actually the box because they don't want to be reliant on the cloud. The cloud can, of course, still complement the box, so that when internet is available, that multiple boxes, for example, can send that data to the cloud for it to be centrally available. So that's maybe an important point to note. Let's see if I can pick another question out of it. I think let's see how we're doing. We're going a little bit on time. There was a question on the strengths and weaknesses of CAD-TB AI software systems in comparing to other softwares available around the world. I can't comment on other softwares, but I can comment, I think, on CAD-TB. We didn't talk about it in this presentation, really about the history of CAD-TB, but we started with CAD and the research behind it already 20 years ago, long before, artificial intelligence is the hot topic that it is today. Because we've been working on it such a long time, it has really allowed us to get a ton of scientific validation together with partners such as Dennis and many others around the world, leading up to, the 75 publications and more that we have right now. making it the most scientifically validated one, but also because we've been doing this for 20 years, also the most implementations globally, because we've been able to gather a lot of experience in that. So I think that's an important point of it. I think the other point is what we end up seeing in practice, what I mentioned also in my presentation. We were the only organization globally that does both the X-ray and the CAD under one roof, also developed and manufactured by ourselves. So it makes things like training or service support easier, because you never have to question, okay, does it come, if you have a connectivity issue from the CAD provider or the X-ray side, we have one help desk basically to help out with everybody. But I would say, I think that the environment around AI in the TB screening is quite varied. There are a lot of different solutions available, taking different approaches on things. I think the Stop TB partnership and Find have a very good presentation or website called AI for Health, where you can see a ton of them. But that would be my 2 cents on CAD-TB specifically. And of course, maybe good to mention and to close off with, because we're going a bit over time, we will also be at the Union conference. I think many of our partners and everybody globally on the call will also be there. We hope to see you there again in person. It's the first one in person after, I think, Hyderabad in 2019. So it's been a long time since we had an opportunity to meet each other and see each other again in person. So we hope to see all of you in Paris to connect on this further. I apologize, I didn't have the time to go through I think there's more than 35 questions that came in. Please be assured that the full Q&A with all of the questions and all of the answers will be shared with everybody who attended and also who registered for the webinar. And so will also the recording, as well as different other assets that we mentioned. So with that, I'd like to close. Apologize for going a bit over time. Thanks again to Elvis, Lillian, Dennis as being our speakers here today, for our team for helping to facilitate, to organize it, and for all of you that made time in your busy schedules to join it. So thanks again, and we'll see you in the next webinar. Thank you.